Amutha Rani, so MD Anesthesiology. She is the president of ISA Tamil Nadu. So her she is a fellowship in clinical endocrinology at the Department of Anesthesiology and Critical Care, Tirunelveli Medical College and Hospital, Tamil Nadu, and a president of ISA Tamil Nadu, and a vice president of IMA Nillai branch. She is executive member of IMA South Zone 2021, board member of IS Studies, Tamil Nadu, Dr. MGR University, Tamil Nadu Medical Council Observer, National COVID Task Force member, National ISA, COVID Clinical Coordinator, Tamil Nadu, received Administrative Excellence Award on Doctors Day 2023 from Tamil Nadu IMA, have received 2 national, 3 state and 3 district awards. So it's over to you, Dr. Amutha Rani, madam.
It's not working. Hello.
Very good morning to one and all. At the outset, I would like to thank the organizers, Usha Devi madam and Manjunath sir and other organizing team members for this opportunity and very good planning and execution, excellent arrangements and hospitality. Thank you so much, sir. My topic is oxygen transport and oxygen cascade. I'm going to give some light, throw light on this context. There is transport of oxygen by the blood, oxygen cascade, oxygen dissociation curve, tissue oxygenation and hypoxia. Oxygen transport in the body. By mechanical act of breathing, oxygen in the air reaches the alveoli. Exchange of gases in the alveoli by which oxygen passes from the air into the blood. The oxygenated blood transported to the tissues by circulation. At the level of tissue capillaries, oxygen enters into the cells and mitochondria. What is oxygen cascade? The steps by which partial pressure of oxygen gradually decreases from the atmospheric pressure and then from the high level in the inspired gas to the lower level at the level of mitochondria. Partial pressures of oxygen at various levels are: at the atmospheric air it is 159 millimeter of Hg, inspired air 149, alveoli 104, arterial blood 100, tissue level 40, at the level of mitochondria it is 2 millimeter of Hg. What is partial pressure? The pressure exerted by a gas in the volume occupied by a mixture of gases. Dalton's law of partial pressures. Total pressure exerted by a gaseous mixture is equivalent to sum of partial pressures of individual gases. Henry's law. Individual partial pressure is proportional to the fraction, that is concentration of gas in the gaseous mixture. The steps of oxygen cascade. Partial pressure of inspired oxygen, that is PiO2. PiO2 is influenced by barometric pressure and the fractional concentration of oxygen, that is FiO2 in the air. PiO2 is calculated by barometric pressure multiplied by the FiO2. That is, barometric pressure is 1 atmospheric pressure is equivalent to 760 millimeter of mercury. Then normal FiO2 in the air is 21%, as you all know. So the FiO2 is, PiO2 is 760 into 21 by 100, that is 159 millimeter of mercury. The partial pressure of oxygen in the saturated moist air is, that is, the inspired air is saturated and diluted with the water vapor along the respiratory tree while passing through the air passages. So the water vapor, that is PP at 37 degree of body temperature is 47 millimeter of mercury. So the PiO2, saturated PiO2 is barometric pressure minus water vapor pressure multiplied by FiO2. That is 760 minus 47 into 21 by 100. That comes around 149 millimeter of mercury. This is the starting point of the oxygen cascade. At the level of alveolar oxygen tension, is down the respiratory tree, oxygen tension is further diluted by the alveolar CO2. So, the alveolar O2 pressure is barometric pressure minus water vapor multiplied by FiO2 subtracted by PaCO2. So, 760 minus 47 into 21 by 100 minus 46. So, it comes around 103 millimeter of mercury. So, PaO2 decreases when there is decreased barometric pressure, increased alveolar CO2, decreased FiO2. So, in hypercapnic patient at high altitude, they would have a substantially lower alveolar oxygen tension. At the level of arterial blood, the PO2, that is PaO2, is given by the formula that is 102 minus age by 3. The normal range is 60 to 100 millimeter of mercury. The main mechanism for hypoxemia are increased alveolar arterial content, decreased alveolar oxygen tension. Alveolar arterial gradient is PA, the alveolar pressure minus arterial pressure. This depends on three factors, that is diffusion across the alveolar membrane. There are shunts, physiological and anatomical shunts, and then VQ mismatch. Factors affecting the oxygen cascade at each level, from the atmosphere to the tissue level. Atmosphere to alveolus, the high altitude, barometric pressure is less and the FiO2 is also less, that is less than 21%, hence the PiO2 is decreased. Water vapor adds to this factor, that is higher the water vapor, lesser will be the PiO2. At the level of alveolus, as I said, CO2 concentration plays a major role. Amount of CO2 in the alveolus depends on the metabolism and the degree of hypoventilation. The partial pressure of oxygen decreases in certain conditions where CO2 production is also more. For example, fever, sepsis, malignant hyperthermia, there is increased CO2 production. At the level of alveolus to capillaries, there is chances of ventilation perfusion mismatch, slow perfusion and shunts. Ventilation perfusion mismatch. The pulmonary venous blood is a mixture of pulmonary capillary blood from all the alveoli. So, the PO2, the pressure of oxygen, is lower than alveolar pressure in that area. In normal lung itself, the upper zones are overventilated, as you all know, while lower zones are relatively less ventilated, but the perfusion is more in the lower areas than the upper zones. Slow perfusion, that is the diffusion is affected in many of the pulmonary diseases where there is slow perfusion, diffusion. So normally the diffusion is very rapid and is completed by the time of blood has passed through the 1/3 of the way along the pulmonary capillaries. At the level of arterial blood to tissues, the PaO2 depends on one, that is serum hemoglobin level, percentage of hemoglobin saturated with oxygen, then the cardiac output, then amount of dissolved oxygen. The shunts, normally a small anatomical right to left shunt arises from the bronchial circulation and the Debatian veins. When the blood passes from the right to left side of the heart without taking part in the gas exchange, the deoxygenated venous blood mixes with the arterial blood, thus reducing the PaO2. What is anatomical shunt? There is bronchial circulation and also through the Debatian veins. The most of the venous blood from the larger airways drains directly into the pulmonary veins, returning to the left side of the heart. The Debatian veins are a small amount of coronary blood circulation, which from there the blood drains directly into the heart, 4 chambers of the heart via the Debatian veins. So directly into the heart, so there is shunt. This is anatomical shunt, the pictorial diagram. Sorry. What is a functional shunt? Pulmonary portion of cardiac output passes through the alveolar capillaries, which has insufficient alveolar ventilation to fully oxygenate all of their blood. So, there is some amount of functional shunt. What is VQ mismatch? Any area of lung with relatively more perfusion than the ventilation results in functional right to left shunt, causing further reduction in PaO2. The overview of cascade, that is oxygen cascade, the PaO2 in dry atmospheric air is 160 millimeters of mercury. Then humidified air, it is 149 millimeters of mercury. Then in alveolar air, it is 104. And then in arterial blood, it comes to 100. Near the tissues, it is 40. At the level of mitochondria, it is 2. The transport of oxygen by blood, that is in two forms. In combination with hemoglobin, that is 98%. As dissolved in plasma, it is 2%. The arterial blood contains about 20 ml and the venous blood contains about 15 ml of oxygen per 100 ml of blood. Thus, about 5 ml of oxygen is transported per 100 ml of blood from the lungs to the tissues or to the cells. This is a pictorial explanation. As the oxygen tension in the tissue level is much lower, the oxygen present as the physical solution in plasma first passes from the plasma to the tissues by diffusion. As a result, oxygen tension in the plasma decreases. The oxyhemoglobin in RBC being exposed to the low oxygen tension in the plasma, the oxyhemoglobin then dissociates and releases oxygen. Then the oxygen from the RBC enters into the plasma and it is carried physically as a dissolved solution. Again, this physically dissolved oxygen leaves the bloodstream and enters into the tissues. The proportion of oxygen dissolved by physical solution as a physical solution in plasma remains always constant. This is measured as tension of oxygen in the blood. Dissolved oxygen is 2%. Very small portion of total oxygen is carried in the blood as a physically dissolved solution. That is 0.003 ml per 100 ml of blood per 1 millimeter of pressure. Henry's law applies here, states that the concentration of any gas in a solution is proportional to its partial pressure. Gas concentration is also directly proportional to the partial pressure. Dissolved oxygen in arterial blood is thus solubility coefficient multiplied into 100, that is 0.003 ml per deciliter into 100 is equal to 0.3 ml. This small quantity of oxygen is very important because this alone reflects the tension of oxygen in the blood. As oxyhemoglobin 98%, oxygen combines with the hemoglobin to form the oxyhemoglobin, which is a reversible process. Oxygen quickly combines with hemoglobin in the alveolar capillaries, where the partial pressure of oxygen is high, that is 104 millimeters of mercury. Equally, oxygen gets dissociated from the hemoglobin in the tissue capillaries quickly, where its tension is very low, that is 40 millimeters of mercury. The one hemoglobin molecule binds to 4 oxygen molecules. You all know that. It's a physiology from the Guyton. 1 gram of fully oxygenated hemoglobin contains 1.34 ml of oxygen. At an arterial PO2 of 100 millimeters of mercury, hemoglobin is 98% saturated. Thus, 15 milligram of hemoglobin in 100 ml of blood will carry about 20 ml of oxygen. The hemoglobin is essentially either fully saturated with oxygen or desaturated fully due to cooperativity. This cooperativity is responsible for the peculiar sigmoid shaped line, that is ODC, oxygen dissociation curve. Oxygen dissociation curve. After 90% of saturation of hemoglobin by oxygen, the availability of receptors on hemoglobin for binding of oxygen suddenly declines. Then the oxygen combines with the hemoglobin very slowly and saturation rises gradually to 100%. After that, oxygen saturation of hemoglobin does not rise further as all the hemoglobin are combined with the oxygen and nothing is left, but the only oxygen tension of the blood can be raised indefinitely without any limit. Thus, the graphical representation of this whole event of relationship between the percentage of saturated oxyhemoglobin and the gradually developed tension of oxygen in the blood forms a ODC. What the ODC actually it tells about percentage of saturation of hemoglobin by O2, tension of oxygen in the blood, total content of blood oxygen in the blood, availability of oxygen in the tissues. Factors influencing the oxygen dissociation curves are CO2 tension, hydrogen concentration, types of hemoglobin, temperature, and the concentration of 2,3-DPG. The influences of these above factors on ODC can be expressed by P50. What is P50? Oxygen tension at which hemoglobin is 50% saturated. Normally, P50 value is 27 millimeter of mercury. It contains that it means that 50% of saturation of hemoglobin by oxygen, the oxygen tension in blood reaches to 27 millimeter of mercury. This is a ODC curve. There is an unloading zone and there is a loading zone where there is shift to the left. There is when there is decreased temperature, decreased 2-3 dpg, decreased hydrogen concentration and the decreased cardiac output. There is a shift to right when there is increased temperature, increased 2-3 dpg and increased hydrogen ion concentration. Again, the causes are the left shift to the causes are alkalosis, hypothermia, abnormal hemoglobins and reduced 2-3 dpg levels. When the right shift causes are acidosis, increased PCO2, increased concentration of 2-3 dpg and increased temperature. What is Bohr effect? Oxygen binding affinity of hemoglobin is inversely related to the concentration of carbon dioxide and hydrogen concentration. The shift in position of the ODC caused by carbon dioxide entering or leaving the blood is known as Bohr effect. On entering the RBC, the following reaction occurs, that is CO2 plus water, carbonic acid, then it is becoming hydrogen ion and the bicarbonate. When the blood flows through the tissue capillaries, then the gradual increase in CO2 tension in the plasma, which shifts the ODC to the right, and the affinity of hemoglobin for the oxygen is also reduced. Thereby, the oxygen is released into the tissues. In pulmonary capillaries, the lowering of CO2 tension due to its gradual release in alveoli shifts the ODC to the left. Thus, the affinity of the hemoglobin for oxygen increases and facilitates the uptake of oxygen in the alveoli. Factors influencing 2-3 dpg levels are, that is, increased 2-3 dpg, chronic hypoxemia, anemia, acidosis, exercise, pregnancy, pyruvate and inosine level, hormones like thyroid and androgen influences, decreased 2-3 dpg are stored blood, hemoglobin F and alkalosis. Excuse me. Abnormal hemoglobin like methemoglobin, carbomonoxy hemoglobin, hemoglobin C and hemoglobin F, they have low P50 values, thereby high O2 affinity of these two hemoglobin. So it causes tissue hypoxemia and stimulates increased RBC formation, results in polycythemia. It is because of these hemoglobin do not bind with the 2-3 dpg. Then tissue oxygenation. The amount of oxygen delivered to the tissues depends upon one, blood flow, that is cardiac output. The second one, the quantity of oxygen carried by the blood, oxygen content. Then the rate of diffusion depends on the inspired oxygen content. Then the hemoglobin content. Oxygen content. The total quantity of oxygen carried by 100 ml of blood. That is 1 gram of fully oxygenated hemoglobin contains only 1.39 ml of oxygen at 100 millimeters of mercury. Average hemoglobin level in an adult is about 15 gram per 100 ml. An arterial PaO2 of 100 millimeters of mercury. Hemoglobin is 100% saturated. So the total oxygen content in 100 ml of arterial blood at 100 millimeters of pressure is 1.39 into hemoglobin multiplied by percentage of saturation plus 0.003 multiplied by PaO2. That comes 21.15 ml, that is around 21 ml per 100 ml. In the venous blood, if you calculate, it comes around 15.75 ml per 100 ml. So, tissue extracts only 21.15 minus 15.75. So the tissue extracts only 5.4 ml of oxygen. So the normal, if the cardiac output is 5 liters per minute, overall 250 ml of oxygen is utilized by the tissues per minute. The amount of oxygen, that is distribution of amount of oxygen at arterial and the venous blood. The oxygen concentration of plasma, that is 0.3 ml per 100 ml. In the venous blood, it is 0.13 ml per 100 ml. Partial pressure of oxygen in the blood is 100 millimeter of mercury. In the venous blood, it is 40. The oxygen saturation is 100% in the arterial blood. In the venous, it is 75%. Now we will see something about hypoxia. The failure to receive adequate quantities of oxygen by the tissues. There are some types of hypoxia: hypoxic hypoxia, anemic hypoxia, stagnant hypoxia, histotoxic hypoxia, and the conditions where the P50 is low. Hypoxic hypoxia, defective oxygenation of blood in the alveoli of lungs. Incomplete saturation of hemoglobin by oxygen, thereby less amount of oxygen is available in physiologically dissolved form, causing low oxygen tension and in the arterial blood. Thereby the hypoxic hypoxia occurs. So the hypoxia is produced by in the following conditions: when there is reduced PO2, that is in the inspired gas. This is due to fall in FiO2 during the rebreathing, or when there is gas with hypoxic mixture. There is when there is fall of barometric pressure, reduced alveolar ventilation, reduced diffusing capacity, abnormalities of pulmonary mechanism, and there is venous admixture and shunts. Fink effect or diffusion hypoxia, you all know this is due to nitrous oxide and nitrogen in the barometric pressure. Anemic hypoxia, reduced oxygen carrying capacity in the blood causing anemic hypoxia. It occurs in anemia, carbon monoxide poisoning, methemoglobinemia and sulfhemoglobinemia. Stagnant hypoxia, when there is reduced hypotension, hypovolemia, cardiac output, reduced cardiac output, peripheral vasoconstriction, trauma, arterial occlusion due to embolia, atheroma. Histotoxic hypoxemia, the defect lies in the cellular mitochondria level, which impairs the utilization of oxygen by the cell and produces hypoxia. If poisoning like cyanide, nitroprusside inhibits the cytochrome enzymes which are involved in the oxygen utilization, results in the inability to use the oxygen at the level of cells, thereby it causing histotoxic hypoxia. Causes of postoperative hypoxia. There are three types of hypoxia can occur: hypoxic hypoxia, stagnant hypoxia, and anemic hypoxia. Diffusion hypoxia, as you all know. Postoperative, there is increased ventilation perfusion mismatch, so it is anesthesia induced. Hypoventilation can also causes hypoxia. Intraoperative hyperventilation causes hypoxia. Spontaneous ventilation may not get triggered, producing hypoxia. Thank you.